Due to having been a general practitioner for 30 years, I'm very familiar with the highly demanding and, in a certain sense, very special conditions for a GP's work, dominated by two phenomena. Firstly, an increasing familiarity with particular patients over time, allowing for insight and proximity, and secondly, encounters with all kinds of health problems, facilitating pattern recognition both on individual and on group level. A predominant phenomenon as to such pattern is currently termed multimorbidity. Differentiated from what is termed comorbidity, denoting states of bad health where one disease is judged as prior to other ailments or diseases, the term multimorbidity applies to persons who suffer from several diseases either sequentially or simultaneously. All GPs know patients in this category. In fact, encountering patients who are suffering due to multimorbidity is the most common professional situation in general practice and one of the most demanding tasks for GPs. I want to challenge the previous formulation by saying the most demanding setting in general practice is the GP's encounter with a person suffering from what medicine conceptualizes as a number of different diseases. The concept of different, however, does only apply when states of bad health are strictly separable in terms of etiology, pathogenesis, treatment, and prognosis. Consequently, the concept is invalid if these preconditions are not met. Then the question is, on which level does medicine differentiate etiology or pathogenesis? If two diseases have a pathological characteristic in common, let us say inflammation, are these two diseases then still different? And if they are judged to be different, due to which criteria? Inflammatory processes may affect all types of bodily material, so to speak, as for example nerve cells in one case and connective tissue in another. This difference in type leads to wide differences as to symptoms and resulting impairments. But both states of illness can be treated in the sense of slowed down or even blocked, though not healed, by the same chemicals, namely substances counteracting inflammation, since these drugs act on the hormonal parts of the immune system. Anti-inflammatory drugs are in many cases sufficient, yet in other cases even more radical medication is necessary, namely cytostatic drugs, limiting excessive immunological processes on cellular level. Since inflammation is the pathological property underlying both types of diseases, is inflammation to be regarded as causal? The next logic question is then, what causes the physiological complex termed inflammation? In an evolutionary perspective, it is the organism's response to being acutely hurt, acutely traumatized, safeguarding the central processes in healing wounds, repairing damaged tissue, and preventing blood loss, and so on. This engenders my next question. Does this connection strictly apply to acute physical wounds only? The current answer is quite clear. No, we have solid evidence that also experiential hurt or trauma can cause inflammation. We now know that the schism between physical and psychical trauma is an illusion, an artifact of the biomedical dualist and reductionist frame of references. Solid evidence bespeaks the fact that host defense mechanisms respond in the same fashion to both. Well, when considering that these conditions apply to acute traumatization, what about chronic trauma, such as being exposed to violence, war, social crisis, and other kinds of constant threat in the sense of a life characterized by poverty, stigma, powerlessness, harassment, marginalization, suppression, or exploitation? The answer is that all ways of being in the world as being continuously and existentially threatened engender processes that affect the most central bodily systems, safeguarding viability and vitality, These are encompassing the hormone, immune, and central nerve systems, the systems for regulation of glucose, lipids, and minerals, and the autonomous systems regulating sleep, breath, digestion, muscular tonus, and body temperature, among others. All these systems are affected, both separately and in their complex interaction, causing what is termed multi-system physiological dysregulation. A very typical pattern of multi-system dysregulation, namely hypertension, hypercholesterolemia, obesity, diabetes 2, depression, chronic pain, and sleeping problems, leads me to one of my patients, Sonja Solberg, and her condensed life story. She says, and I quote, "My father was 25 years old when, in 1940, he was taken by the German Nazis in occupied Norway while distributing flyers. Together with my grandfather and my aunt, he was sent to a concentration camp in Germany. My relatives survived and were saved by the Red Cross, but all three of them started to drink after coming home. This was before I was born. But as long as I can remember, my father was drunk almost every day. When he was drunk, he was violent and he attacked my mother. He never touched me, however. He was like Dr. Jekyll and Mr. Hyde. When he was sober, he was calm, reading books. In those situations, I loved him. When drunk, he screamed and commanded, and he was the boss and called me a whore since I was a schoolgirl. On the other hand, I was Daddy's girl, and he told me those stories from the time in the camp, how he was forced to collect and transport corpses and things like this. He used me as a container for all his bitterness and desperation. I was his waste bin. During all my life, I felt not good enough, always fearful, always alarmed, always scared of what would come next. I've let many people step on me. My first husband was an alcoholic who, which I gradually find out, also abused drugs, and he died of an overdose. I should have saved him, despite all the trouble he had. My next husband was also glad in liquor, but not like the first one, and I regarded him as my savior from my loneliness and depression after my first marriage. But he left me after many years in favor of a much younger woman. I should have taken better care of myself, staying attractive, so he would not have gotten astray. My youngest son got into trouble with drugs for some years. Certainly, I should have foreseen this when leaving him with his father and the young woman, because I thought he needed his friends and I couldn't remove him from there. Anyhow, he is on the right track now, but I was in constant alarm for many years because he was several times found drugged and unconscious." Unquote. Sonja states that this life in constant tension, constant alarm, and overwhelming duties has somatized her. She has repeatedly suffered from severe depressions. She has been treated for vaginal hemorrhage for 15 years, resulting in countless interventions without any solution of her problems, namely pelvic pain and bleeding, until she got her uterus removed long before the menopause, and a chronic inflammation of her uterine lining was confirmed. By then, she had been diagnosed with hypertension, high blood lipids, and diabetes 2, and medicated with several drugs in accordance with the traditional assumption of these health problems as separate diagnoses. In addition, she had become grossly obese, whereby contributing to other health complaints such as pain in hips and knees and difficulties in regulating her diabetes. Sonja's health problems endanger her life and render her prone to die prematurely. Obesity, hypertension, hypercholesterolemia, and diabetes are well acknowledged as independent risk factors for cardiovascular disease and stroke. In combination, their adverse impact accumulates, and in order to prevent such dramatic events, each medication she, in an additive way, has been administered represents a new danger. There is no evidence as to how this cocktail of drugs, each of which has been tested separately in RCTs, strictly excluding persons like Sonia because multimorbid, interact in human bodies in general, in case there exist general bodies, and in Sonia's lived body in particular. There is solid documentation that polypharmacy is among the top 10 causes for admission to hospital by now. This figure is yet another artifact of two biomedical frameworks and their special interaction, namely that of reductionism and of evidence-based medicine. Whenever a physician prescribes a drug for the state of bad health defined as a disease entity, and then adds yet another drug for even several based on the same assumption, there is not required what current medicine deems to be the most appropriate basis for medical decisions, advice, action, and treatment, namely evidence. In short, whenever a doctor prescribes 2 or more medications to a particular person who is not identical with the average patient included in the relevant RCTs and meta-analyses, and who is this, may I ask? This doctor literally does not know what he or she does. The nexus of multimorbidity, guidelines, and causality, the most common clinical reality in general practice, is offering us reflection time on the deepest problem connected to this nexus, which in fact is that GPs are judged both in terms of performance and adherence by means of guidelines as the measures of all things, although there are no guidelines for their most common tasks. Even worse, guidelines for health problems primarily and previously developed by specialists in, for example, neurology for the diagnosis of chronic fatigue syndrome, or in rheumatology for the diagnosis of fibromyalgia, have been handed over to GPs along with the patients, although exactly these guidelines made by these specialists have proven to be unsuccessful, both in terms of diagnostics and treatment when applied by the specialists. One may rightly ask, why should on earth these templates work in general practice? My claim is that in the stepwise reduction from the whole person attending a clinical encounter to the patient in accordance with the definition of medicine, and to the patient's parts in accordance with the medical interpretation of the actual complaint, there is a crucial loss of information due to the tenacious biomedical assumption of a human being and the human body. The transformation of a particular person to a defined disease entity, or a number of these in the same person, results in both alienation of a person from her or his life world and a thingification for medical purposes such as taxonomy and classification. What is lost in translation may be the most salient source of knowledge as to origin of the health problem, the lived experience, both igniting and maintaining the inflammation, for example, and the multiple disturbances on physiological level that nourish bad health and cause premature death. The prevailing concept of causality, derived from the master science of physics, does probably apply to the inanimate nature, in other words, to the nature of nature. However, it does not apply to the nature of human beings. Even if we replay the former master science with biology, the science concerning the animate nature, the central criteria for causality still guiding the master methodologies are actually the very obstacles to arrive at adequate knowledge about the nature of humans. Human beings are hybrids, both nature and culture. Consequently, there is no valid method to find the truth about their being, but several. Two parallel or similar developments are worth consideration and analysis. one in the humanities, notably philosophy and literature, and the other in scientific medicine. Postmodern criticism and the subsequent abolition of one truth about the human condition can be regarded as having opened the door, so to speak, for a coup that hijacked its core arguments and which, as at present, transforms to a phenomenon called post-truth. Now, everybody claims authority to a truth about the state of the world, locally and globally. One authority has been exchanged with many authorities, which all request to be adhered to. This development seems similar to the initial protest of doctors and researchers against dogmatic, authoritarian medical statements about how to understand human sickness and their origin and how to treat them. This movement, termed evidence-based medicine, has by now metamorphosed into an authoritarian regime even more rigid than the previous. Just as philosophers and scholars of literature now are concerned with regard to post-truth, physicians and researchers at the Center of Evidence-Based Medicine here in Oxford have acknowledged that the criticism against EBM becomes ever more explicit, detailed, qualified, and justified. Yet, while certain groups find themselves comfortable when manipulating the truth with alternative facts, the leader of the EBM Center declared that they aim at correcting the regime in order to limit for its rather comprehensive and unwanted side effects and unintended spin-offs. In biomedicine, an approach conceptualized as biopsychosocial has been introduced as the profession's response to the increasing critique of the dehumanized or depersonalized biomedical practice. As the name alludes to, the concept embraces three kinds of knowledge that are considered true in three disciplines: the scientific of biology, the humanistic of psychology, and the hermeneutic of sociology. Clinicians claim that they adhere to this model. However, so far, the medical curricula do not mirror this statement, since a systematic training of medical students regarding an insight into the humanistic framework and methodologies and in the basic rules of hermeneutics on the same level as the natural sciences is still absolutely lacking. This implies that equity of these three frameworks for acquiring true knowledge is not provided. The scientific frame of references trumps the other two. Thus, the concept's name is misleading and its clinical application is pretense. I conclude. Due to the continuous lack of scholarship in the humanities and in hermeneutics among medical professionals, highly overdue changes in medical research and clinical practice do not occur. Medical professionals are socialized to think that scientific truth, grounded in the episteme of the natural sciences, is the most or even only reliable ground on which to base medical decisions. Within this frame of references, the only possible positions are either materialism, everything is matter, or dualism, matter is separate and different from mind. These positions, however, leave no room for the most human characteristics. Humans are relational and social beings and creators and conveyors of meaning. Whenever these characteristics are overruled by methodological orthodoxy or pragmatism, the resulting knowledge does not do human beings justice. Actions based on such grounds cannot be but ethically untenable. Thank you for your attention.